partager. Laurent, you can start the recording. Good morning, good afternoon, and perhaps good evening. Welcome to the first episode of the three-part WHO Health Workforce Action Series on COVID-19. The action series is conducted under the themes of the International Year of Health and Care Workers, Protect, Invest, Together. In this episode, we'll be focusing on the theme of Protect. We have an exciting panel of speakers from Togo, from Brazil, from the International Labor Organization, and from Women in Global Health. We're really looking forward to presenting this series and to speaking with you and to sharing lessons learned. We're going to start off with a quick overview. Before we start, I'll just say that all of your microphones were muted when you began. Please use the Q&A to ask questions. If you have any technical difficulties, you can use the chat, but the chat will not be monitored for questions and answers. Now, similar to at services, when you sit when you get there late, you sit in the front queue. Please ask your questions nice and early so that we are able to ensure that we can get those to our speakers. This webinar will be translated into French, Spanish, Portuguese, Arabic, and Russian. And we have the great pleasure of having a talented team of interpreters. Should you wish to change languages, please use the bottom right button for interpretation. We will have presenters in different languages, as represents well our learnings from around the globe. So please be familiar with where the interpretation button is. There will be a survey at the end. The results will be anonymized, but we certainly hope that you will respond and share your insights on what you're experiencing and what you think the future for Protect means. If you are joining us with social media, please use the hashtag support healthcare workers. I'm Catherine Kane. It is my great pleasure to be with you today, and I'm really looking forward to sharing with you some very exciting speakers. I'm going to lead off with Dr. Giorgio Cometto from the Health Workforce Department. Giorgio was leading the development of the health workforce and COVID-19 guidance, and also has been leading the Action series. Over to you, Giorgio.
Thank you, Catherine, and good morning, good afternoon, and good evening, colleagues from around the world. It's a pleasure to welcome you to this first event of our series. Sorry, it's not advancing the slides. Kindly bear with us, we're having a
One moment, please.
Sir, if I may, you need to click on the slide first with your mouth. Just click one time on the screen, then you can move with the mouse.
Thank you. And apologies about the small inconvenience. I think we need to start a conversation on the protection of health workers from a sober assessment of the reality in front of us. Since the COVID-19 pandemic started, millions of health workers got infected, thousands have died, and we have witnessed an unprecedented level of disruption. The majority of countries around the world report that their delivery of essential health services have been negatively affected, with the health workforce issues representing one of the key reasons behind the interruptions. More than 84 countries have recorded labor strikes or other forms of industrial action, and there has been a staggering rise of the prevalence and incidence of a number of mental health issues and conditions. Particularly on the issue of infections, this has been quite central in the policy debate and in countries' response. We must admit that even now, more than a year into the pandemic, we don't necessarily have as accurate a picture as we would like. The reporting is uneven, the quality and the completeness of data is uneven, but some broad trends emerge. Initially, during the first months of the pandemic, there was a clear trend toward a high percentage of healthcare workers among the cases, the reported cases of infection, but subsequently data over the subsequent few months demonstrate that the percentage decreased and progressively became closer and closer to the incidence in the general population, possibly indicating a successful rollout of infection prevention and control measures, as well as the wider availability of personal protective equipment. This happened in a context in which many countries around the world faced a pre-existing set of challenges related to lack of availability, maldistribution, and other challenges affecting the quality and the performance of health workers. On top of that, as part of the COVID-19 response, many health workers had to be redeployed or reassigned, in addition to those that were lost temporarily to infection or quarantine, and in some cases, unfortunately, to death. Another element of the picture is that additional requirements are coming in, not just in the context of the response in terms of the provision of additional clinical services, but also for the rollout of the largest immunization campaign in history. So these factors conspire to determine a situation in which pre-existing challenges have been exacerbated and warrant a comprehensive response to both protect the existing health workers as well as increase the availability through new investments in education, jobs, and learning. WHO's normative guidance in this area is very clear. One of the key themes, one of the pillars of WHO's guidance on health workforce policy management in the context of the COVID-19 pandemic is exactly around offering health workers the support and the protection that they need. This includes, of course, infection prevention and control, including adequate personal protective equipment, screening and testing as applicable, but goes beyond this. It includes an agenda around decent working conditions, avoiding overwork, avoiding stigma and discrimination, and especially investing in decent work, including adequate remuneration, overtime payment, paid sick leave, avoiding incentives that would encourage workers to show up at work even while ill, and a number of other related policy measures. Some of these themes are really core and central to the campaign linked to the International Year of Health and Care Workers. At the World Health Assembly last November, member states recognized the critical contribution that many health workers made and the sacrifice that they made in the response to the pandemic, designating 2021 as the International Year of Health and Care Workers. But this is not just about celebrating and commemorating. This is also about taking concrete steps, concrete actions to address some of the shocking numbers that I presented earlier. It means commitment from member states, from international financing institutions, from national and international stakeholders to invest in the protection of health workers, as well as in their support and adequate management. It means prioritizing health and care workers in the immunization campaign. And at the international level, it means joining a policy dialogue on establishing a care compact to protect health and care workers to go in the direction of upholding their rights and improving their working conditions and their practice environments. An element within this that I need to emphasize, which is central to our broader agenda, but that is acquiring particular relevance this year, is the gender elements. A new initiative is emphasizing the importance of creating gender equal leadership opportunity, protection of female health workers who represent approximately 70% of the health workers globally from sexual harassment and violence, and other aspects, including crucially closing the gender gap as part of an equal pay drive and recognition. We'll hear more about that from other speakers later in the session. So I would like to conclude by asking all of you, your respective institutions, to join us in the campaign to advance these themes, and I look forward to your contribution in today's discussion. Thank you.
Thank you, Giorgio, for leading off our discussion. And clearly, applause is not enough. What we really need to do is focus our collective attention on ensuring that we protect and invest in health workers, and that we gain this global solidarity that we have all sought in order to end the COVID-19 pandemic. Now, in consistently with the theme of protect, we all know that it is important that health workers have personal protective equipment, that they are trained in infection prevention and control measures. I turn this over now to an esteemed colleague from Togo, Mr. Kajanta Cha, who is the Director of Human Resources for the Ministry of Public Health and Universal Health Coverage. He is also the coordinator of the Human Resources for Health Network in Francophone Africa. Kajanta, la parole est à toi. Alors, ton micro, c'est... On ne t'entend pas.
Vous m'entendez?
Oui, tout à fait.
Merci beaucoup. Merci aussi de m'offrir l'occasion pour présenter l'effort que fournit le Togo dans la lutte contre la pandémie à COVID-19. Un instant, bon, OK. Je disais que je vous remercie sincèrement de m'associer à cette campagne pour la protection des personnels de santé dans le contexte de la réponse contre la COVID-19. Donc, je vais faire une présentation qui va tourner autour de deux points. D'abord, je vais décrire le cadre organisationnel de la réponse au Togo. Ensuite, je vais m'étendre sur la gestion des ressources humaines, et cela en 6 points. Le premier point concernera les besoins en personnel de santé et les stratégies de mobilisation de ce personnel pour la riposte. Ensuite, je vais décrire la réorganisation des services pour la protection des personnels de santé lorsque la pandémie s'est déclenchée. Je décrirai le cadre motivationnel que le pays a mis en place pour encourager les personnels de santé pour mieux faire leur travail. Ensuite, les formations qui ont été dispensées pour renforcer les capacités des agents à mieux prendre en charge les malades. Et enfin, les résultats concernant la prise en charge et la continuité des services. Je vais décliner quelques défis et perspectives et je conclurai à la fin. En guise d'introduction, je dirais que le Togo est un pays de l'Afrique de l'Ouest avec une superficie de 56 600 km² et une population de plus de 7 millions d'habitants en 2020. Le nombre des agents du secteur de la santé était de 15 214 en 2019 contre 18 372 en 2020 et un ratio personnel de santé traceur population de 7,01 pour 10 000 habitants en 2019 contre 8,24 en 2020. En 2020, OK. Le Togo, comme bien de pays, a été frappé par la pandémie de la COVID-19 depuis le 6 mars 2020. La présente communication aura pour objet de montrer comment ce pays a organisé ses ressources humaines en santé pour la réponse contre la pandémie, même si les données présentées ici ne sont pas issues d'une enquête ou bien d'une étude précise, mais c'est du vécu d'un acteur de la lutte. Je vais d'abord vous donner quelques éléments de la situation épidémiologique de la semaine qui date du 4 mai. À ce jour, nous avons 13 010 cas confirmés, 11 269 cas guéris, soit une proportion de 86% parmi les cas confirmés. Nous avons eu à ce jour 123 décès, soit une létalité de 0,95% parmi les cas confirmés. Le nombre de cas actifs à ce jour est de 1618. Nous avons 882 cas confirmés parmi le personnel du secteur de la santé, donc 719 professionnels de santé, 210 infirmiers, 159 médecins, 146 techniciens de santé, 32 accoucheuses, 69 sages-femmes et 112 aides-soignants contre 30 pharmaciens. Nous avons également 163 personnels d'appui qui ont été infectés. Le nombre de contacts à ce jour se chiffre à 40 357 contacts et 40 157 ont été mis en auto-isolement et suivis. Le nombre de tests réalisés à ce jour s'élève à 312 269, soit 403 tests pour 10 000 habitants. Dès la notification du cas index et l'identification des cas contacts, le pays a déclaré l'état d'urgence sanitaire conformément aux dispositions de la loi portant Code de la santé en République togolaise et le règlement sanitaire international. Plusieurs actions ont été mises en œuvre. D'abord, la création d'un organe chargé d'organiser la riposte, notamment la coordination nationale de la gestion de la riposte, qu'on appelle CNJR, par un décret en date du 30 mars 2020. Ensuite, on a créé une cellule sectorielle de gestion de la riposte au sein du ministère de la Santé, au titre de laquelle il y avait une session spécialement dédiée à la protection du personnel de soins et au redéploiement du personnel de santé pour la riposte. Il faut noter que la cellule sectorielle avait pour mission de piloter l'ensemble des activités de riposte du ministère de la Santé, de l'hygiène publique et de l'accès universel aux soins. À ce titre, ce comité sectoriel devait plutôt assurer le leadership global pour la riposte à la pandémie, élaborer un plan de préparation et de riposte, déterminer une vision, des buts et des objectifs communs à la riposte, établir des priorités immédiates à la riposte, superviser toutes les activités de la riposte, valider toute activité des comités, notamment les plans de contingence et d'action, le budget et le plan de communication. En application des attributions de la cellule sectorielle, un plan d'action budgétisé a été élaboré prenant en compte les besoins urgents en personnel de santé, des formations et le renforcement des capacités. Un centre hospitalier régional, en l'absence de structure, a été transformé en centre national de référence pour le traitement de la COVID-19 et il a été créé 9 centres de prise en charge dans les régions. Les besoins en personnel et la stratégie de mobilisation, qu'est-ce que nous avons fait? Les besoins urgents en personnel de santé pour la riposte ont été exprimés et intégrés au plan de riposte. Mais l'État togolais n'a pas organisé un recrutement spécial pour la riposte, pour disponibiliser le personnel pour la riposte. Mais qu'est-ce qui a été fait? Nous avons procédé au redéploiement du personnel d'autres structures sanitaires dans les centres de traitement et de prise en charge. Ensuite, pour la détection des cas, notamment dans les équipes d'intervention rapide et dans les surveillances au niveau des portes d'entrée. Nous avons fait également recours au personnel des services de santé des armées qui est venu massivement appuyer et rendre opérationnel le Centre national de référence pour la prise en charge des cas de COVID à Lomé. Nous avons également fait recours au personnel temporaire, aux volontaires, aux apprenants des dernières années des écoles de formation en santé. Et nous avons également fait recours à des personnels financés par des partenaires techniques de l'État, tels que l'OMS, l'UNFPA, qui ont mis un certain nombre de consultants ou bien d'experts à notre disposition. Le Togo avait bénéficié à l'époque aussi d'une mission sanitaire de Cuba, qui est venue également appuyer les équipes sur le terrain, surtout en termes de recherche des cas dans les régions à l'intérieur du pays. Il y a également mutualisation dans l'utilisation de certains spécialistes. Je donne l'exemple des réanimateurs. Le Togo n'a pas plus de 10 réanimateurs sur toute l'étendue du territoire. Et donc, pour gérer les cas graves, il fallait utiliser en commun ces réanimateurs qui sont à cheval sur les centres de traitement et les hôpitaux dans le cadre de la continuité des services. Qu'est-ce qui a été fait pour protéger les agents en début de crise? Donc, pour éviter que les agents de santé ne se contaminent en chaîne, on a réorganisé le système de travail en créant une rotation du personnel, en mettant en congé des personnels qu'on considère non essentiels et en adoptant le fonctionnement des services en fonction des bouclages des zones. Nous avons également mis à disposition du matériel et équipements de protection individuelle par l'État, y compris parfois avec l'appui des acteurs syndicaux qui ont mobilisé ces équipements puisqu'à un moment donné, ça manquait sur le terrain. Et donc, en dehors de ce que l'État mettait à disposition des agents pour leur protection, les acteurs syndicaux ont également mobilisé et permis de protéger efficacement les agents dans la riposte. Nous avons également intégré ces acteurs-là dans la gestion, dans l'utilisation de ces équipements-là pour qu'il y ait plus de transparence. Pour aider également ces agents-là à mieux donner le meilleur d'eux-mêmes, l'État a essayé de créer quelques indemnités. Donc, des incitatifs ont été accordés. Des primes mensuelles forfaitaires ont été accordées au personnel intervenant en première ligne, telles que dans les équipes d'intervention rapide et les personnels travaillant au point d'entrée. Une prime mensuelle substantielle a été également octroyée au personnel travaillant dans les différents centres de prise en charge. Cette prime est mensuelle et va parfois jusqu'à l'équivalent du salaire mensuel de l'agent. Et l'État a également institué une assurance pour compenser et prendre en charge le personnel de santé qui a été contaminé. Et donc, en plus de ça, lorsque la vaccination a été introduite, les personnels de santé furent les premiers à être vaccinés Et aujourd'hui, le pays a quand même vacciné plus de 70% de son personnel de santé. En termes de renforcement des capacités également, un certain nombre de formations ont été mises en place, notamment sur les préventions et le contrôle des infections, la surveillance également pour renforcer la capacité de détection des cas, la prévention et la prise en charge, et la communication et la gestion des rumeurs. Pendant ce temps, quels sont les résultats que nous avons pu obtenir en termes de continuité des services, puisqu'il n'y avait pas que la COVID-19, il y avait les maladies que nous connaissions. Donc, on s'est évertué à faire en sorte que tous les centres, en dehors de la prise en charge des cas, puissent continuer à offrir, à garantir la disponibilité des services tels que la vaccination, les CPN et les accouchements assistés. En termes de défis pour le pays à ce jour, c'est de se poser la question de comment faire pour intégrer le dispositif de la riposte dans la gestion de la continuité des soins et services. Ensuite, comment restaurer la confiance de la population envers les formations sanitaires qu'elles ont complètement désertées par crainte de se faire infecter. Et donc, en termes de perspective, on s'est dit, la COVID-19 a réveillé, a soulevé et démontré clairement les faiblesses en matière de disponibilité des ressources humaines. Et il y a eu beaucoup de partenaires qui, dans l'élaboration des projets avec les pays, ont posé le recrutement de personnel de santé comme conditionnalité. Donc, je donne l'exemple de la Banque mondiale qui a dit clairement que dans son projet, le recrutement d'un certain nombre de personnel de santé constituait une conditionnalité. Nous, on se dit que c'est une bonne perspective pour le pays. En guise de conclusion, je dirais que la pandémie de la COVID-19 est une redoutable épreuve pour les systèmes nationaux de santé. Elle a clairement mis en évidence les faiblesses de nos santé et provoqué un désamour de nos populations pour les établissements de soins. Toutefois, tant bien que mal, ils ont su gérer la situation malgré les contraintes et se montrent de jour en jour à même d'assurer la continuité des services et des soins. Le début de la vaccination peut être considéré comme un réel motif d'espoir malgré quelques réticences. Je vous remercie. Donc voilà ce que j'avais à partager avec vous en termes de pratiques faites par le Togo dans le cadre de sa réponse à la COVID-19. Je vous remercie.
Merci, Kajanta. Thank you for highlighting some very important threads with regard to ensuring that there are decent numbers of health workers for the response, to ensure that we use a whole of society response and bring in additional workers to supplement those who are already there. You've also highlighted the fact that globally we already were facing a shortage of health workers, and now we are layering additional responsibilities onto them. I appreciate also that you mentioned insurance and priority for vaccination. I will note right now that we already do have one winner in the first question category. Thank you, Kate Green, for putting in your question. Please, everybody know that we do welcome your questions throughout the presentation, so don't be shy. Next up, and following on the thread that Kajanta so nicely illuminated with regard to training of health workers, I have the pleasure of presenting to you O Senor Geraldo Pontes. He is the technical advisor for the National Council of Health Secretaries, CONAS, in Brazil, and responsible for the areas of work management, education management, indigenous health, and social control. Por favor, ligue sua câmera e microfone. Oxau, essa seu. Desculpe.
Bom dia. Este é o último slide que está aí. Este é o final. Precisamos ir para o primeiro. Eu quero primeiro agradecer fortemente o convite. This is the end slide, and no the first slide. Oh, gracias, thank you, obrigado. Eu quero inicialmente agradecer fortemente o convite que nos foi feito e a oportunidade de mostrar e conversar com vocês sobre o trabalho que nós estamos realizando aqui no Brasil já há alguns anos e fortalecido agora com a pandemia. Next, please. Eu sou Haroldo Pontes, eu trabalho no CONAS, no Conselho Nacional de Secretários Estaduais de Saúde do Brasil. Next, please. E que país é esse? Um país continental, imenso e com grandes desigualdades. Um país com 211 milhões de habitantes, distribuída em 5 regiões, 27 estados e 5.570 municípios. Next, please. Mais um Brasil que, apesar de desigual, tem um sistema único de saúde, o SUS, que protege o conjunto dos brasileiros e dos aqui que moram. Desde o final da década de 80 e início da década de 90 do século passado, nós temos um sistema de saúde que tem como princípio a universalidade do acesso para todas as pessoas que moram aqui, a integralidade da assistência, a participação da comunidade por meio dos conselhos de saúde, Conselho Nacional de Saúde, conselhos estaduais e os conselhos municipais de saúde, e que tem como característica e como princípio a descentralização política administrativa nas várias esferas de governo. Portanto, não é um sistema hierarquizado em que o Ministério da Saúde coordena sozinho as ações. O Ministério da Saúde, os estados e os municípios são responsáveis pelas ações de saúde. Next, please. Aqui um resumo da legislação que trata do SUS e da educação em saúde. A Constituição Federal de 1988 já define que cabe ao SUS ordenar a formação de recursos humanos na área da saúde. A Lei 8.080, que é a nossa lei orgânica da saúde, define que a organização de um sistema de formação de recursos humanos em vários níveis, inclusive de pós-graduação, e a elaboração de permanente aperfeiçoamento de pessoal também é responsabilidade do SUS. E uma política específica de educação e saúde, também registrada em leis, que define a estratégia do Sistema Único de Saúde para a formação e desenvolvimento dos trabalhadores. Next, please. Portanto, observem que nós enfrentamos um desafio de, na área da saúde, ter toda uma formatação de ações de educação e saúde. A Política Nacional de Educação Permanente é, portanto, uma estratégia do Sistema Único de Saúde para a formação e o desenvolvimento dos seus trabalhadores, que tem como pressuposto a aprendizagem significativa, ela tem que fazer sentido para as pessoas, e ela reconhece, na sua definição, o caráter educativo do trabalho. Portanto, a partir do trabalho, nós constituímos os elementos da educação, entendendo como um espaço de problematização, diálogo e construção de consensos no próprio serviço. Next, please. E o trabalho, portanto, do CONAS, que tem como missão apoiar as secretarias estaduais de saúde, promover a disseminação de conhecimento e desenvolver troca de experiências. Um dos projetos, portanto, que eu aqui vou abordar, desenvolvido em parceria com a OPS Brasil, quero sempre destacar isso é muito importante para nós, é de apoiar a ampliação e o fortalecimento de escolas estaduais de saúde pública. Next, please. Este, de novo, é um mapa do Brasil que mostra para vocês a distribuição dessas escolas. Nós temos, atualmente, 19 escolas estaduais de saúde pública distribuídas em quase todo o país. A área que não temos, essa área mais vazia, em cima do mapa, é a nossa região norte, região amazônica, que tem um conjunto para nós de dificuldades de implantação, de serviços, de escolas, mas no restante do país nós temos uma distribuição homogênea dessas instituições de ensino chamadas escolas de saúde pública. Next, please. O que as caracteriza? Primeiro, que todas elas são vinculadas às secretarias estaduais de saúde. São responsáveis pela formação dos trabalhadores, dos gestores e também para os usuários do sistema na formação e sua capacitação. Atendem a diversidades de situações e são responsáveis por desenvolver formação técnica profissional. Aqui eu me refiro ao técnico de radiologia, técnico de enfermagem, técnico de saúde bucal, agente comunitário de saúde, como também cursos de pós-graduação para o conjunto dos trabalhadores da saúde pública. Next, please. Portanto, desenvolvem, num ambiente compartilhado, a relação entre educação e saúde, formação e trabalho e ensino e serviço. Next, please. Adotam as escolas as ações de educação na perspectiva do processo de trabalho. Como é que nós elaboramos a formação a partir do trabalho realizado? Utilizam a integração educação e trabalho e consideram a unidade de saúde, o local de saúde, como um espaço privilegiado, um cenário privilegiado para desenvolver o ensino e aprendizagem. Next, please. As atividades, já citei, cursos técnicos de pós-graduação, mas aqui destaco que também realizam eventos, seminários, congressos e atividades de pesquisa e têm publicações. Next, please. Aqui já começo a mostrar para vocês o exemplo deste trabalho desenvolvido em parceria com a OPAS. Primeiro, que nos últimos anos nós ampliamos o número de escolas de 12 para 19, realizamos um diagnóstico que teve como resultado uma publicação, um livro que fala das escolas de saúde pública, as suas contribuições pedagógicas e políticas institucionais para o SUS. Criamos, isso aqui é para nós muito importante, uma rede colaborativa dessas escolas e um repositório de informações, de modo a que, num único local, é possível acessar o conjunto de atividades, informações, formulações, dissertações, teses sobre educação e saúde. E trabalhamos o fortalecimento dessas estruturas voltado para a educação à distância. Era uma área pouco desenvolvida pelas escolas, mas que passaram a ser fortemente desenvolvidas com a necessidade imposta pela pandemia e pela dificuldade de deslocamento neste momento tão difícil. Next, please. Esses projetos atuais destacam, portanto, a ampliação do número de escolas, a criação da rede colaborativa, a capacitação para a indexação de publicações e o fortalecimento da educação à distância. E aqui, esse último item é que quero, já indo para a conclusão da minha exposição, exemplificar como um trabalho que realizamos. Tratei do conjunto de ações, agora vou para um único exemplo, que é o de fortalecimento da educação à distância. Next, please. Aqui, neste gráfico, nos mostra que, no momento preciso de crescimento da pandemia, nós precisávamos desenvolver um conjunto de atividades autoinstitucionais, cursos, a serem oferecidos para o conjunto das escolas. E assim fizemos. São 4 cursos já desenvolvidos pela OPS, pela OPAS, um deles de cuidados clínicos da síndrome respiratória aguda grave, o outro, projeto de unidade de tratamento de síndrome respiratória, um terceiro de prevenção e controle às infecções causadas pelo coronavírus, e o quarto, doenças ocasionadas por vírus respiratórios emergentes. O que é que nós fizemos? Pegamos esses 4 cursos com a OPAS e ofertamos para que cada uma dessas escolas o desenvolvesse. Algumas delas fizeram do modo em que estava, outras adaptaram e acrescentaram elementos à realidade que eles vivem nos seus estados. Next, please. Aqui um quadro já do resultado desse trabalho. para cada um desses cursos, à esquerda, o conjunto de estados brasileiros e embaixo o total de oferta. Já foram acessados, isso é dinâmico, muda a cada dia, 8.343 trabalhadores de saúde no Brasil já desenvolveram, já se capacitaram em algumas dessas atividades. Observem que, principalmente, com mais de 4.000 trabalhadores formados, as doenças ocasionadas por vírus respiratórios emergentes. Mas aqui um quadro detalhado por estado e por curso e a formação de cada um dos trabalhadores. Next, please. Aqui o outro exemplo que quero apresentar, que é o de formação junto com a OPS, com as OPS e o Campus Virtual de Saúde Pública, de atividades para o fortalecimento das escolas, para desenvolver as atividades. Fizemos 2 desses, todos eles com o objetivo de contribuir para o desenho de propostas educativas virtuais. Para as equipes pedagógicas dessas escolas, para 80 profissionais destas equipes, uma formação que teve como objetivo fortalecer as capacidades dessas escolas para o desenho de projetos de educações virtuais. Portanto, as equipes pedagógicas das escolas foram capacitadas por nós, pela OPAS e pelo campus, para poder desenvolver essas atividades educacionais. E o outro, voltado para os profissionais de tecnologia da informação, com o mesmo objetivo, para qualificar esses profissionais e suas equipes para estruturar esses cursos na modalidade de educação à distância, porque isso exige da nossa parte toda uma preocupação sobre a interatividade da ação e sobre a participação das pessoas nesta formação. Next, please. Pode, next, next and next. Isto. More. Aqui, os desafios que nós temos para a implantação desse projeto. Já falei o tamanho do país, a necessidade permanente de capacitação, um perfil epidemiológico complexo, caracterizado para nós pela tripla carga de doença, a própria pandemia e o fortalecimento da educação à distância. Next, please. Nosso objetivo junto com a OPS nesse processo, portanto, é de mobilizar os estados, viabilizar as escolas, contribuir para o seu fortalecimento e disponibilizar cursos da OMS em português via campus virtual de saúde pública. Next. Já concluindo, este é o exemplo, este é o livro que falei antes, só para dizer que, pelo sítio do CONAS, todo mundo pode acessar um conjunto de publicações que nós temos, são muitas publicações que são de acesso livre e são de acesso gratuito para todas as pessoas que têm interesse, porque a nossa instituição é uma instituição pública. Next, please. Next. Uma fotografia para exemplificar a oficina que aqui realizamos. Nesta fotografia, inclusive, vocês podem achar aí Mônica Padilha, que tem sido uma parceira fundamental para o desenvolvimento desse trabalho. And next, and uma mensagem de Paulo Freire para todos nós. Ensinar não é transferir conhecimento, mas criar as possibilidades para a sua própria produção ou a sua construção. Muito obrigado. Thank you very much.
Muito obrigada, Haroldo. Thank you, and especially for that inspiring quote at the end with regard to the reason that we teach and the reason that we learn. I appreciated very much that you drew in threads with regard to mobilizing networks, with regards to diversity, to unity of effort. It's not easy in a large country, but it sounds like There was a great deal of thought that was put into how to present education through a variety of modalities in order to ensure that health workers were protected with the knowledge that they needed in order to do their jobs and in order to use the tools and equipment necessary to fight COVID-19. I have the very exciting opportunity now to introduce to you someone who has been leading the fight for decent work. Ms. Manuela Tomei is the Director of Conditions of Work and Equality Department at the International Labor Department. She led the preparatory work that culminated in the adoption of the latest two ILO conventions on violence and harassment in the world of work, we're against, and on decent work for domestic workers, we're for. It's very exciting to bring to you someone with this portfolio among our distinguished speakers today. Manuela, the floor is yours, please.
Thank you very much, Catherine, and good morning, good evening, and good afternoon to everyone. I thank the WHO for inviting the ILO to participate in the first webinar of its action series to mark the International Year of Health and Care Workers. Protecting the working conditions of millions of workers in the health and social work sectors globally is both a moral and legal obligation, which is integral to employers' duty of care. And it is particularly necessary for at least two reasons. First, if workers in our health and social work systems are not adequately protected, rewarded, and supported, there will be no sustained and inclusive recovery from the pandemic, no resilient societies and economies. And second, improving the working lives of health and care workers would also help empower women economically and advance gender equality. As it was already said before, women account for 63% of health and care workers across regions, but they constitute 70%, if not more, of the workforce in half of countries. During my intervention, I would like to do three things: to share a few facts concerning the working conditions of these workers, drawing also upon a couple of ILO WHO studies, a few measures that have been adopted by selected governments during the current pandemic to address some of these challenges. And third, I would like to offer some suggestions on how to move forward. With regard to the facts, as it has already been highlighted, health and social care workers have been at the forefront of the fight against the COVID-19 pandemic, but too many have lost their lives while saving other people's lives. And as it has already been highlighted, poor or lack of personal protective equipment, understaffed hospitals, long working days, lack of proper equipment are among the reasons for these losses. The WHO and the ILO conducted in the early stages of the pandemic a global survey on health workers' perceptions of risks concerning a number of factors such as the work environment, infection and prevention and control, occupational safety and health, among others, and also their perceptions about the adequacy of related preventive and mitigation measures. Despite some differences across countries by the level of income, the region, gender, and occupational category, all participants concurred that the risks to healthcare workers are high and preventive protective measures insufficient. Of notice is that 52% of the respondents said that exposure to infectious materials was an unacceptable risk. And across all regions, over 54% of participants singled out psychosocial risks as the most unacceptable hazards and measures to prevent violence, harassment, and bullying by superiors, peers, and patients largely inadequate. Women, who constituted 65% of respondents in the survey, were especially vocal about these risks. And indeed, exposure to work-related violence and harassment has been high in the health sector compared to other sectors already before the pandemic, but the pandemic has worsened further. There have been reports of physical and verbal attacks against doctors, nurses, and health staff by family members of COVID-19 patients or neighbors ostracizing them for fear of infection. Pay is another area of concern. The average pay in the health and social work sectors, especially in occupations in which women prevail, is low compared to sectors where the workforce is balanced or is dominated by men. Moreover, the gender pay gaps in the health sectors are particularly large and often exceed those estimated for the overall economy, sometimes doubling them. These and other findings have emerged from a forthcoming WHO-ILO global report on gender pay gaps, which is also looking into the underlying causes. And among this, endemic occupational segregation along gender lines and the undervaluation of women's work, in particularly in female-dominated occupations, are among these causes, together also with contractor arrangements. Temporary or zero-hour contracts that again tend to prevail in occupations held predominantly by women in the sector are also part of the problem. And the situation of community health workers in countries with serious health personnel shortages is even more dramatic, often working informally without pay, training, and means or social protection. They face greater risk of infection. It is clear that national health systems faced with the pandemic of these scales have not been fully able to protect health and care workers. And the failure to continue doing so will further worsen the current shortage in labor supply of these workers globally that the panelists who have preceded me have highlighted. We certainly cannot afford it, but on a positive note, there are some countries that, and we have heard some of these experiences, have developed innovative measures to help lower healthcare workers' exposures to contracting the virus, have provided psychologically counseling and reduce family care pressure. Many G20 countries in particular, because it's part of the employment working group within the current Italian presidencies of the G20, there have been reports relating to this particular issue. Many G20 countries, as I was saying, have revised and updated their OSH national plans through new relevant protocols and guidelines, such as cleaning procedures, orientation regarding the use of personal protective equipment, contract tracing of COVID-19 cases, and social distancing rules. Other governments have increased also health workers' compensation. This happened also in Togo through allowances and additional remuneration, either on a permanent basis, this is the case of France, or on a temporary basis, such as in South Africa or the Russian Federation. And this is an important first step to recognize the essential role of all health workers in responding to the pandemic. A number of other countries have also very importantly recognized COVID-19 as an occupational injury, whether an accident or a disease, and have therefore extended work insurance benefits to workers in the health sector who have contracted or died from COVID-19 in performing their duties. The Republic of Korea supported health workers and their families with free internet services and education on human rights violations against nurses or COVID-19 related personnel. France has set up a telephone hotline for healthcare workers, and some hospitals provide also security guards to accompany them on their commute to and from work. Other countries, including Algeria, have introduced policies and legal ordinances protecting healthcare workers from physical and verbal attacks. Equally important has been the award of paid pandemic leave for health workers, including in long-term care, such as in Australia, and in other countries, childcare facilities have been authorized to remain open with a skeleton staff to look after essential service workers' children. While important, these measures are patchy, are of a temporary nature, and very modest in scale. And the pandemic has shed light on the cracks in economic systems that have poorly prioritized investments in the care sectors, leading to shortages in health workers and poor working conditions. We need to do much more and better everywhere. And looking ahead, there are at least 5 points that we believe we should look into. The first is increasing investments in health and care sectors. The physical infrastructure needs to be improved, chronic understaffing tackled, and working conditions enhanced. Ensuring stable, sustainable health workforces in all countries is important also for health emergence preparedness globally. Second, OSH, occupational safety and health, including mental and health well-being, needs to be a higher priority on the policy agenda. Healthy and safe workplaces have proven key to preventing the virus spread. The occupational safety and health response, particularly in the healthcare sector, needs to be integrated within wider emergency and public health responses with good surveillance and promotion mechanism. Investing in OSH in the healthcare sector is beneficial to both, ensuring the health of workers as well as the public who they come into contact with. Third, OSH measures have to be gender responsive, namely address the specific circumstances and needs of men and women who work in the health sector. This is even more relevant in the case of the health sector, in which, as we have seen, the bulk of the workforce comprises women. This means, among many other things, putting in place effective measures to prevent work-related violence and harassment, including sexual harassment. This means set adequate remedies and sanctions, enhance awareness, and deliver training. And ratifying Convention 190 of the ILO, which is the first international treaty on violence and harassment in the world of work, is one concrete step to prevent and tackle this problem. Fourth, the historic undervaluation of women's work in the health sector needs to be addressed. The Equal Pay International Coalition, which is spearheaded by the ILO, OECD, and UN Women, can indeed help in this respect. This is a coalition which disseminates methodologies and tools on how to advance pay equity in the private and public sectors, encourages the sharing of practices, laws and other policies on how to reduce the gender pay gap and tackle the discriminatory part of it, and generates new evidence and knowledge. And fifth and last point, protecting health workers means providing them with social security coverage, including access to healthcare and employment injury benefits in case of occupational accidents or illnesses. And as I said before, this requires recognizing the occupational diseases that are specific to the health sector, such as COVID-19. So in conclusion, the COVID-19 outbreak has shown how vital is the work performed by healthcare workers and how poorly they are often treated. The situation is untenable. COVID-19 has made it abundantly clear. More investments in the health sector, including in OSH, promoting equal pay for work of equal value, and the elimination of violence and harassment can make the health sector more gender equal, effective, and resilient. Let's not waste this crisis. Thank you very much for your attention, and over to you, Catherine.
Manuela, thank you. That was inspiring. I enjoyed especially the 5 points that you put forward for action at the end of your response. I would hesitate even to try to summarize them as beautifully as you did. One particular element of what you said caught my ear, which was the idea of a patchwork of measures across countries. In my culture, there's something called a quilt, where you take pieces of fabric and you sew them together and you create a blanket. It sounds to me like you're proposing that we create a quilt, a security blanket, to ensure that health and care workers no longer bear the dubious honor of being heroes, but instead bear the honor of decent work, paid, protected, respected, with a fair salary and an opportunity for career advancement. I really enjoyed, of course, the gender elements that you brought in, which brings me actually to our final speaker, who will speak, I'm positive, eloquently, especially on the gender issue, as well as on the importance of valuing and protecting health workers throughout the spectrum, from those who are highly educated and all the way through to those who come from the community and provide essential health services, especially to those hardest to reach. I have the honor of presenting to you now Dr. Iris Mwanza, who is the director of the Community Health Roadmap and also the co-chair of the Women in Global Health WHO Gender Equity Hub. Iris, the floor is yours.
Thank you so much, Catherine. Thank you. Good morning, good afternoon, and good evening. I'm delighted to join you today to discuss this really important topic of decent work for health and care workers. I think we all have a sense of what decent work means. We certainly know when we don't have it, but the official definition from the ILO goes as follows. Decent work involves opportunities for work that are productive, that deliver a fair income, that provide security in the workplace, social protections for families, better prospects for personal development and social integration, freedom to express concerns, freedom to organize, to participate in decisions that affect our lives, and equal opportunities and treatment for all men and women. Next slide, please. I'll begin with the profile of the global health workforce. We've already heard that women make up 70% of the workforce. They deliver health and care to 5 billion people, and they contribute $3 trillion. Yes, that's trillion with a T in GDP every year. So clearly global health and gender are inextricably linked. As a result, we would expect that this is a great industry for women, right? An exemplar of progress, a paragon of decent work. Yet the sad reality is it is not. Next slide, please. In a landmark report called Delivered by Women, Led by Men, the Gender Equity Hub shared the research findings, and they were really sobering. 5 key findings were: first, although women make up 70% of the workforce, they hold only 25% of leadership positions. Second, women face systematic gender bias and discrimination, robbing them of opportunities for advancement. Third, although women's contributions to health are substantial, as I mentioned, to the tune of $3 trillion, half of that figure is unpaid and underpaid work. As an example, millions of community health workers are compensated with small stipends or in-kind incentives instead of salaries. Fourth, and we've heard this from our colleagues before, Giorgio and Manuela, violence, workplace violence and sexual harassment in general is widespread and is even worse in the health sector. An ILO multi-country study published back in 2002 found that the health sector is the most dangerous place to work, accounting for 25% of all reported workplace violence, with later studies showing that the situation is even worse now. Yet in many countries, there are few legal or other protections. Sexual harassment, for example, isn't even against the law in as many as 60 countries. And fifth, men dominate the higher status, higher paid roles, with gender norms and stereotypes reinforcing segregation to the disadvantage of women. The outcome isn't just disadvantaged women. It's weaker health systems with dire consequences for all of us, for everyone's health, and a huge barrier to achieving the SDGs and universal health coverage. Next slide, please. We've already heard, and I think everybody knows this, that if it wasn't clear before, COVID-19 has exposed and exacerbated long-standing inequities. We see women bearing the brunt of this crisis, carrying the far greater burden at home and at work. For example, community health workers are expected to include COVID-19 sensitization, surveillance, community care, in addition to continuing to provide their regular essential health services. But often they're asked to do this without extra pay, often without adequate PPE. And in many countries, they have not been included as official frontline health workers eligible for vaccination. So in effect, we have the poorest women subsidizing global health and risking their lives and the lives of their family without providing adequate pay or protection. And this is unacceptable. It's unethical. And it in fact epitomizes indecent working conditions. As we heard before, we also see an increase in violence against women. According to UNFPA, there have been 31 million more cases of gender-based violence. We know that female health workers are even worse off than before, but it's hard to quantify exactly by how much because many countries simply do not collect this data. Next slide, please. The outcome of this is financial, physical, mental burnout, infection, and even death. The situation is so intolerable that many health and care workers understandably want out. They want to leave the health sector altogether. We also know, and we've heard previously, that we can't afford this as most health systems are already overburdened and grossly understaffed as is. I believe the projected figure of 18 million additional health workers needed by 2030 is going to have to be revised upward and significantly as a consequence. Next slide, please. There are actions that will ameliorate the current situation. Unfortunately, there are no quick fixes. There's no silver bullet, but the following 5 asks could help address some fundamental failings. Ask 1, include women in global health security decision-making. Diversity always leads to better decisions and better outcomes. Ask 2, provide health workers with safe and decent working conditions. Ask 3, that women's health and care is valued, that is recognized, that is paid and paid adequately. Ask 4, adopt a gender-responsive approach to health security data collection and analysis. As mentioned, many countries do not collect disaggregated data. Ask 5, fund women's movements to unleash their power and their full potential and ability to address some of these critical gender issues. Women's groups are underfunded, and clearly there is so much work to be done. Next slide, please. So this isn't just the right thing to do, it's the smart thing to do, and it will yield a triple dividend of gender equality, yes, but also better health outcomes for all of us and economic development. So what is not to like? Next slide. This is such an important year for action. The COVID-19 pandemic provides new impetus and momentum to make the systemic changes needed to protect health and care workers. As we all know, it's the International Year of Health and Care Workers, putting special focus on protecting and investing in them. It's the year of the Generation Equality Forums to secure the commitments already made to advance women's rights. It's the year of the Gender Equal Health and Care Workforce Initiative, which is a collaboration, I think Giorgio mentioned, between the government of France, the WHO, and Women in Global Health to catalyze action. And this is the year the ILO Convention 190 on the elimination of violence and harassment at work, including gender-based violence and sexual harassment, enters into force. And this will happen next month. We can't achieve our goals, our global goals, our national goals, or win the fight against this pandemic and future pandemics without addressing gender inequity and gender inequality systematically. COVID-19 is our global wake-up call to build back better, and 2021 is the year. Last slide, please. I thank you so much for your time and attention. I invite you to join us at the Gender Equity Hub if you're not already a member, or join and support the any of the many, many amazing women's groups out there. Thank you so much.
Thank you, Iris. That was absolutely magnificent. Magnificent, and I would say eloquent in a way that I've just represented, not all of us are. So you've made a very clear set of 5 asks that we will again share with participants at the end of this, this discussion. And I think you've highlighted some really critical elements, not only for women, but for workers at all ends of the spectrum. You have questioned, and I think very cleverly, if the health and care workforce is full of women, and if this should actually represent an opportunity, how can we afford not to realize the promise of the health and care workforce? I'm going to start with some questions and answers. For the panelists, please keep in mind that we'll have approximately 2 minutes for each of your answers, but we'll come back to you with additional questions and send a summary out with the recording of this event. The first one, and again, well done, Kate Green, for being the first person to ask a question. For Togo, were there any existing mechanisms, governance structures, or planning documents that helped establish the cellule sectorielle? Kajanta? Si tu as ton micro, on t'entend pas.
C'est bon?
Ah, tu es là, parfait.
Ok, je suis là. J'ai pas entendu la dernière portion de la question. L'auditeur voulait savoir si le gouvernement a mis en place un dispositif. De quoi je n'ai pas entendu vers la fin.
Oui, quel était le cadre, les politiques qui vous ont laissé construire, établir la cellule sectorielle? Y avait-il avant la pandémie?
Non, en réalité, avant la pandémie, il y avait des cadres, hein, tels que le comité sectoriel santé, mais comme c'était une pandémie et qu'il y avait une dimension à menacer la survie de la nation, il est prévu dans notre code de la santé que lorsque ces événements adviennent, qu'on puisse déclarer l'état d'urgence. Et donc, pour gérer cette pandémie, cela ne relève pas seulement du secteur de la santé. Il a fallu bien d'autres secteurs tels que les finances, la fonction publique. Et donc, c'est ça qui a permis que, en se basant sur le code de la santé et le règlement sanitaire international, qu'une coordination nationale soit mise. Maintenant, pour que le secteur de la santé ne soit pas, pour ne pas dire, dessaisi de sa mission naturelle, une commission sectorielle a été mise en place qui est chargée maintenant de la mise en œuvre des actions techniques sur le terrain. Donc, voilà un peu ce qui a été fait et les fondements.
Merci. Une question pour, sorry, a question please for Haroldo in Brazil. What was the percentage of health workers who were covered by the training offered?
Eu preciso do seu português.
Could the translators help me with this? My mind isn't functioning in Portuguese.
I can help if you wish.
Por favor.
A pergunta é de saber se o porcentagem dos trabalhadores que foram atingidos pela formação em linha foi suficiente.
Obrigada.
Obrigado pela pergunta. O país é muito grande. Nós atuamos uma faixa. Portanto, o conjunto de trabalhadores, eles têm vários locais onde eles estão sendo capacitados permanentemente. Não, nessa dimensão, por mais que nós façamos, não é suficiente. Não é suficiente. Pra vocês terem uma ideia dos números, nós temos no país mais de 1 milhão de trabalhadores da saúde, nas mais diversas categorias, Mas aqueles cursos que eu mostrei, eles são específicos para determinadas faixas de trabalho. Somando essa atividade com outras que nós desenvolvemos, sim, nós estamos conseguindo capacitar o conjunto dos trabalhadores que estão na linha de frente, mas não só com aquela atividade. Aqueles 8.000, quase 9.000, somado a outras ações que nós desenvolvemos. Aqui no Brasil, como no mundo inteiro, todos os trabalhadores tiveram que aprender muito e ainda estão aprendendo muito a pandemia. No número que eu mostrei para a formação específica dos profissionais das escolas, sim, suficiente. Quando nós, juntos com o Campus Virtual de Saúde Pública e a UPS Brasil, atuamos para formar 80 trabalhadores da área pedagógica e 80 trabalhadores da área de tecnologia da informação, nós conseguimos suprir essa necessidade de formação para desenvolvimento de cursos. Os outros, de autoaprendizagem, número de 9.000, sozinho, não. Mas somado com outras atividades que nós temos, sim.
I'll follow with one more question. First, it was offered in English and Portuguese, so I'll give both. I would like to ask a question, which is different from the role of these public health schools in front of the other schools or educational institutions in Brazil? Eu gostaria de fazer uma pergunta para Haroldo. Qual é a diferença no papel de estas escolas estaduais de saúde pública frente a outras escolas ou instituições educativas no Brasil? Desculpe.
Não, eu lhe garanto que your English é melhor que o meu. O seu português é melhor do que o meu inglês. Parabéns. Vamos à questão. Vamos à questão. Veja só, nós temos no país, é claro, um conjunto de instituições formadoras, universidades, ligadas ao Ministério da Educação, que desenvolvem suas atividades, as mais gerais. O que nós observamos com a constituição do Sistema Único de Saúde, que eu aqui rapidamente descrevi, que nós precisávamos de algo específico que considerasse a particularidade da formação em saúde, da educação em saúde, e considerasse o tempo, a urgência da gestão e das secretarias estaduais. Então, nós não formamos uma rede de competição com o que já existe. E ela é muito grande, o que já existe. São inúmeras universidades, mas que procurassem, através dessa especificidade, somar as atividades. Portanto, elas têm como característica, porque são vinculadas às secretarias estaduais de saúde, tem como característica a Política Nacional de Educação Permanente, da maneira como eu descrevi, uma aprendizagem voltada para os trabalhadores, com a idade que eles têm, com a necessidade de sentido e com a integração necessária entre trabalho e ensino, e que tem uma característica de como ela faz parte da Secretaria Estadual, como ela faz parte da gestão, de responder aquilo que aparece com a urgência necessária. Por exemplo, nenhuma universidade, por sua característica, tem a agilidade que nós tivemos para ofertar esses cursos junto com o campus virtual e com a UPS Brasil, que eu aqui descrevi. Portanto, o específico e a agilidade para dar respostas.
Obrigada. A question from Manuela. How can every country on earth offer decent work to its health workers? It's an easy one, I assume.
Yeah, a very easy, a very easy question. Well, what I would like to say is that, as it was said earlier on, decent working conditions or decent work comprise a number of components. So it's about recognizing fundamental principles and rights at work to start with. And fundamental principles and rights at work means no child labor, no forced labor, non-discrimination, and the right to organize and engage in cooperation, collective bargaining, etc. It means also a working environment that is safe and that is healthy, which is not putting in jeopardy the life and the health of workers. It is about cooperation between management, workers at the workplace level. It means occupational safety and health systems. It's not just having a law on occupational safety and health, but it's indeed having institutions which are indeed looking into how to organize workplaces in a way that will indeed prevent, reduce exposure to risk of infections in the specific case of the current pandemic. It's about also ensuring adequate wages. Now, obviously, the extent to which, or the sophistication of measures that can be put in place with a view to attaining all these results will depend very much also on the means that countries have, as to the fiscal space that they have with a view to ensuring that adequate investment is made into the health sector. But I think that the current pandemic has actually shown the terrible cracks in the health system, and that this is simply untenable. And we are already seeing now, in the context of discussions and debates about recovering from the pandemic, that investment in the health sectors are indeed seen more as something essential and strategic to recovering back better. Yes, these are the elements, the elements for a response to a very difficult question.
Manuela, I think we're going to have to invite you back for the Invest session, because you've certainly, as one might say in golf, teed up that discussion on investment very well. I have a question for Iris. Have you seen any examples of COVID-19 acting as a catalyst for long overdue policy reforms to advance the rights of women health workers in the health sector?
Yeah, I think that's a really, really good and important question. I think it's still early days. I think there are some green shoots, shall we say, and because we know that out of crisis, oftentimes we see these massive structural changes. I'm thinking of like Liberia after Ebola. They really reoriented, restructured the whole health system, including community health workers. But I think, but for this terrible tragedy, that opportunity would not have arisen. And I think all the speakers today have spoken about the crisis, highlighting all of these fissures and weaknesses in the system. And I think there is a recognition that, yes, something important has to be done. I think there have been quite a lot of policy changes. I think legal changes tend to take longer. I think they're really important. Additionally, I will say it's so important also to have these global conventions. We talked about the ILO Convention 190 that's coming into force next month. It's international law. It's not necessarily self-executing in every country, but it provides huge impetus for national countries to revisit their existing legal structures, and an opportunity for women's groups and others, and there are many, many others who are interested in this sector, to galvanize and push behind, and also hold governments accountable, because usually they will have to come back to the UN or to other international fora and say what they've done. And they love to be able to say, well, yes, we've changed the policy. Yes, we've changed the law. But legal changes, as we know, they do take time. So I'm sorry, I can't come up with a great example right now. I don't know of an example. I know there are some bills on the books in Kenya to restructure and introduce, at least for community health workers, integrate them into the system. That's something where I work and I'm more familiar with. But I think really we're at a real moment of opportunity. And as I said, I think this is the year. This is the year. People are open, they're interested, they're looking for changes. They're looking, I mean, it sounds a bit sloganistic, build back better. But I think there's a real seriousness of intention, and we all know that there is a need. If we have any hope of achieving any of these wonderful global goals that we talk about, be it SDGs, be it universal health coverage. So I'm very optimistic, I'm very hopeful.
That is, I think, a really positive note for us to conclude the question and answer session, and to reflect very well that each of the speakers has shared lessons learned, has shared what has been effective so far. Each speaker has also shared that there are challenges. We're not through this. We haven't solved it, but we have a tremendous opportunity now to really leverage 2021 as the International Year of Health and Care Workers, to leverage these lessons that we've learned throughout the pandemic so far, to continue that momentum through efforts like the Global Care Compact, like the Vaccine Equity Challenge. We have the opportunity to protect health workers and then to invest in health workers to create a world that we're all looking for. With that, I'd like to turn this over to Giorgio Cometto for some final remarks from the WHO Health Workforce, and then I'll just conclude with a couple housekeeping notes and a poll.
Thank you, Catherine, and good afternoon and good morning to everyone again, colleagues. In this afternoon session, we focused on some themes and some issues that relate to the protection agenda. We discussed about governance, we discussed about education, about the social protection agenda, gender issues came out strongly. One point, or rather some points that we had discussed more closely in the equivalent morning session related to, for example, mental health, working conditions, the labor rights of health workers and how these are represented also by labor unions. The take-home message that I would like to leave you with is that protection of health workers is a complex endeavor which requires addressing all these issues at the same time. The individual presentations drew attention and shared evidence and experience on individual aspects, but it is an agenda that has to be conceived and implemented as a whole. It is also an agenda that requires at times additional resources. It may require financing, and it is also finally an agenda that doesn't belong necessarily in a single institutional locus in governments. And this brings me to the two next sessions that we will have on investment and on partnership, the theme of the International Year of Health and Care Workers. Protect, invest together. Invest and together are also the how we will achieve the protection agenda. With that, I would like to thank very much all the panelists for sharing their experiences, for presenting their countries' work and their own experiences. I would like to thank all the participants for the insightful questions and the contribution to the discussion, the moderator, Catherine, the staff that contributed to the organization of the session, Sharada and Beatrice, as well as all the interpreters. Catherine, back to you for the closure.
Let's not forget our friends in IT who have also made this possible for us. I encourage you to take these last few moments to give us your insights in the poll. We will be sharing a link to the recording and presentations along with other related materials in the coming days. If you have questions or would like to contact us, please contact us at workplace2030@who.int. This is the year of health and care workers. You are health and care workers. You represent health and care workers. We ask you to get involved. Please visit the campaign page that we'll be putting up on the screen very shortly and find one way that you'll get involved. Find 2 ways. We offer 5 already, so please join us in this opportunity to make 2021 count. Episode 2 of our action series will take place on June 9th. We'll be in touch to ensure that you have the registration link well in advance, and we look forward to your participation and your feedback. Lastly, but not least, as today's theme has been Protect, I remind you that today is International Hand Hygiene Day. Wash your hands. Please, everybody, take care, and thank you so much for your solidarity, and thanks to everyone who has made this a possibility.
Thank you.